It's a pleasure to be here and join you all at the Mind Foundation speaker series. I would like to share some slides, but before I do, yeah, if you want to check out our work at psychedelic.support is the URL. We have lots of free courses. We also offer trainings and certificate courses that you can go deeper in your knowledge about psychedelics. And I will say this topic of women's health and psychedelics is both a personal interest of mine and also a professional interest, in that the first lab that I ever worked in over 20 years ago was an endocrinology lab, and we were trying to understand how environmental toxins could impact fertility and issues that come up for this exposure to toxins in the environment. So it hasn't really been a big focus in my research, but as I've learned more about psychedelics and the applications that are being developed, it is quite clear that there's a need for more studies, more funding to go specifically to look at the range of health conditions that can come up across the life cycle of women. And so that's what we'll be talking about today. What do we know from the research, and where are the gaps in what we'd like to learn more about? So let's see if I can get my slides up. There we go. All right. Okay, so I'm going to put it on. Are you seeing just the slides or the presenter
Yes,
view?
just the slides. Perfect.
Okay. All right, great. Yeah, so I did share some references that I'll be going throughout the presentation. So hopefully Celine can get you that PDF. But I am very impressed with everybody's background here and interest in neuroscience and as well as therapy. So we want to always be sourcing the information that we're leaning into as far as making conclusions or hypothesis around psychedelics for women's health, because as we'll see, there is not a ton of research that has been done to date on this topic. So this is what we'll be talking about today: why study women. We'll look at the neuroscience of hormones and neurotransmitters, as well as the life cycle of females. We can get some information and understanding about psychedelic medicines from indigenous use of plant medicines that contain psychoactive substances. Then we'll talk more about these anecdotal reports that have come in around women who use psychedelics for mental and physical health conditions. We'll talk about some of the hypothesized neurobiological mechanisms, as well as how psychedelic therapy for mental health may be an intervention that can be applied for some of these topics. And then we'll talk about where the research is heading. So this question of why study women, like what's the difference between populations of men, women, and I would like to just say before I really jump into this that a lot of this can apply to men to better understand women in their life, and to trans individuals who also have fluctuations of hormones and may have some experiences that are aligned with this. So I just want to say that this is more inclusive topic for all people. We can all learn from understanding neurobiology and potential applications for this research. So this topic of why study women, so we know that preclinical research is mostly done in male rodents, and only 15% of the studies that were conducted between 1909 and 2009, so 100 years, were done in both sexes. There's a very lack of research with fMRI studies that are focused specifically on women's health issues. So of the 50,000 MRI brain imaging studies that have been conducted since the 1990s, less than 0.5% have focused on these women-specific health factors. So that's a very tiny amount of all the studies. There are sex differences, obviously, in how our brains and bodies function, and as well as how medications may work in as far as alleviating symptoms, but also the potential side effects that can come from medication use. And we know that from 1997 to 2000, there were 8 out of the 10 drugs that were withdrawn from the market. So this is here in the United States because they cause greater health risk in women. And so that's a really interesting finding of the potential difference in medication side effects. So it's really important that we include females in our non-clinical studies, as well as looking at gender differences as we conduct clinical trials or try to apply treatments. So let's take a review of the menstrual cycle here. Typically, a woman may menstruate, have 450 menstrual cycles over 30 to 40 years in their life. So that's quite a many. It starts with menstruation here at day 1, and this phase can last for 3 to 7 days. This is followed by the follicular stage. It starts the first day of menstruation and ends at the day of ovulation. At this point, several follicles are formed, the lining of the uterus thickens, and we're starting to see this increase in estradiol or estrogen during the first sort of half of the cycle there. At ovulation, which can occur for 24 to 48 hours, we see that estrogen is at its highest peak during the cycle, and it falls to trigger the release of one mature egg. And when we look at this graph here on the left-hand side, we can see that there's this tango between estrogen and progesterone, which begins to rise in the luteal phase as estrogen falls. And then actually we see that both increase a little bit less for estrogen through the end of the cycle there. The modulatory effects of these hormones can be observed in the brain as well. So we're going to take a look at that. And one thing to know is that estradiol is also known as E2, and it's primary form of estrogen during the reproductive years. And it's the most potent form of estrogen. And then the estrone E1 is primary form after menopause. So what happens to your brain during this menstrual cycle? There have been some recent news articles. I picked this up in Scientific America, this 2003 studies recently. There's been quite a bit of media coverage. But first off, we do know from earlier studies that this like change of hormones across the cycle can impact brain structure and function. We see changes in cognition and emotion. We also understand that there's this alteration in neurochemistry between the neurohormones and the interactions with neurotransmitters such as serotonin, norepinephrine, GABA. So there is this kind of like tuning that happens with estrogen and progesterone in the brain. From this, we know that, as I said, different phases of the cycle, different phases of the life cycle, there could be modulation of different emotion and cognition. And there's also an increased risk of anxiety and depression, which I'm going to show some research in a moment to discuss that further. But these recent studies in 2023 were conducted, one with an ultra high field MRI. So it's very precise measurements of 27 women across 6 time points. And they actually did an ultrasound to determine the exact time of ovulation. And then they positioned these MRI measurements around that. They looked at areas of the hippocampus, and they found that the outer layer thickened and gray matter expanded as estrogen increased and progesterone decreased. There's also an increase in the layer involved in memory, which was as progesterone increased, they saw this area thicken and then change over time across the cycle. Another study looked at 30 women, and they estimated these 3 time points across the cycle. And they were looking at white matter thickness and also noted changes. This was the changes in white matter leading up to ovulation, they stated could trigger more efficient information transfer across different parts of the brain, but both studies had the limitation of that they didn't measure whether or not these neurobiological changes were actually associated or causal of memory and cognition. But we do know from other studies that this type of brain activity or connection does change. So this is interesting recent work to sort of highlight this importance of sex hormones for regulating emotion and cognition. So, what about psychiatric symptoms? So, we know that females overall have a higher prevalence of many psychiatric disorders and symptoms such as depression, anxiety, PTSD, eating disorders, Alzheimer's disease. Something like 70% are in women, and other stress related conditions. There's also a heightened risk of psychiatric disorders during the reproductive years, which is when we see the greatest fluctuations of hormones, as well as different transitional points in the life cycle. So, after having a child or during menopause. So, there is a strong evidence that these fluctuations in sex hormones can be a major driver between the difference of prevalence we see between male and females in the risk for psychiatric disorders. There's also environmental impacts that we know oftentimes women are paid less, there's more exposure to trauma, stress. All of these things can interplay with the physiological state of someone that is experiencing symptoms or a disorder. We know that females are more likely to self medicate with drugs or alcohol to try to alleviate stress and anxiety, and they can be more vulnerable to stress induced relapse. And this has been demonstrated in both humans and animal studies. So, if we take a closer look at what is happening across the life cycle, so the top graph is showing the risk for depression. It's looking at before puberty, and then we have this line that signifies that the purple color is women, blue is men. And so these lines start to draw apart around the time just before puberty, at puberty, and we see this increase in risk for women. It's particularly around the time when estradiol can be the highest. And again, people talk about how estrogen has an antidepressant, anxiolytic effects, and this could be like due to the increased serotonergic activity or the promotion of neuroplasticity and neurogenesis, or all of these factors combined. So it may be that at different phases of the cycle, or if there's this regulation of hormones, that we see the likelihood of symptoms to arise. What you also see is the bottom graph notes sort of the cyclical monthly cycle of fluctuating ovarian hormones. And then when we get to the perimenopause phase, so this is on average about 4 years, but can range from 2 to 8 years. In this period, this is when periods become irregular. We start to see really erratic fluctuations of the primary sex hormones. And then once someone reaches menopause, they have not had a period for at least 12 months before. And then we see this postmenopausal phase where the risk of depression starts to join back up with the prevalence in men. And then we also kind of see this tracking of the decrease in estrogen. And so it's sort of like why this might be happening. We know that estrogen and progesterone are active in areas of the brain associated with mood and emotion processing, such as the prefrontal cortex, hippocampus, and the amygdala, as well as the brainstem. And then during perimenopausal depression, it's been suggested that this may be related to dysfunction in the GABA system and the HPA axis in response to stress, as well as this tuning of the hormones and neurosteroid levels. So it's very complicated. And, this is the reason why I think that oftentimes, particularly in the preclinical animal studies, it's just it's more convenient to just study male mice or male rats because of this extra variability in time. And in the rodent models, the estrous cycle is only 4 days compared to the humans in 28 days. So there's a lot of variation that can come in when you're trying to study the brain. And I'd say, nonetheless, that is no excuse, I think, to exclude the female rats from the studies, because if we want to translate this to humans, it's really important that we have a real point of view from what's going on in brains of all genders. Okay, so when we look at the endocrine system, this is predominantly the hypothalamic pituitary gonadal axis, known as the HPG. It involves the hypothalamus in the brain, the pituitary gland, pineal gland, thyroid gland, the parotid glands, thymus, and then the adrenal glands, which are located above the kidneys, the pancreas, and then the gonads, which are the female ovaries or the male testes, which actually releases sex hormones that provide feedback inhibition to these different glands and also to the brain. So this is a really interesting system in how it works, and also the mechanism by which contraceptives are applied to regulate the system and prevent ovulation. The other aspect of the endocrine system is the hypothalamic pituitary adrenal axis, the HPA for short. And this also works with a negative feedback system. You may be more familiar with this from thinking about stress regulation. HPA is highly involved, but also very much part of this hormonal system in the body. Recent time, we've been hearing a lot more about the gut microbiome, but I found it fascinating to learn that estrogen, circulating estrogen, can actually impact this microorganisms in the gut. So it's bacteria, viruses, fungi, trillions of organisms that make up the gut microbiome. And interestingly, as well, is that 95% of the serotonin in the body is actually found in the gut, and only about 5% in the brain and other tissues. So the way that it's been reported is that there can actually be a regulation of how much estrogen is actually active and circulating through the system. So there's a direct two-way connection from the gut to the brain, but then it can also seem to modulate physiological states by modifying or regulating estrogen, and that's circulating throughout the body. And there has been many different disease states at this point that are linked to this gut microbiome, including mental health symptoms. What's interesting too is that sex hormones, I think maybe conventionally we're just sort to be involved in thinking about fertility and reproduction, but really it forms and shapes the brain, as we've already talked about. And it does so, it does so through probably many complex mechanisms, but has a way of interacting with many different neurotransmitter systems in the brain, including serotonin, norepinephrine or noradrenaline, GABAergic, dopaminergic, glutamatergic neurons, and the release of their neurotransmitters. All of these are very important for regulating mood, emotion, reward processing, cognition, and other brain functions. And it's been shown that estrogen can modulate or sort of tune these systems in kind of like a bidirectional way. It can increase, inhibit, it can work in dual or opposing forces. So there's many ways that these hormones can alter the neurochemistry in the brain. So let's take a look at the life cycle of females. If we start off, we start off as children, and then there's this period that starts to happen right before puberty, where hormones start to come on board. We see physiological changes, And then at puberty, this is when women will start to menstruate. At this time, we are going to also start to see issues that can arise from associated with menstruation. So premenstrual syndrome, PMS. A more severe form of PMS is premenstrual dysphoric disorder, PMDD. This is highly prevalent, both PMS and PMDD. It can be characterized um, by bloating, by pain, sleep disturbances, mood disturbances. Many different types of symptoms can come up and can vary in the amount of time that people experience this, from a few days to a week before their period to a few days after. If we go on to the next phase, we see in the life cycle pregnancy. There can be fertility issues, sexual dysfunctions, low libido that comes up. Sometimes these are related to psychological factors, sometimes they're related to physiological factors. Oftentimes, hormonal contraceptives are prescribed during this phase of life, which can change how these natural hormones are flowing through our bodies through the synthetic introduction of hormonal birth control. The next part of the life cycle to highlight is after giving birth. It's a common phenomenon of postpartum depression. This is more recognized the last couple decades, but it makes a lot of sense that after the child is born, the body goes through a lot of physiological changes. The hormones are erratic for a while as they start to stabilize again back to baseline levels. Kind of lesser severe symptoms that can come up for people during this time is adjustment disorders, which can affect both moms and dads. So having a newborn in the house can be a lot of stress, a lot of introduction of changes, a lot of disruption in sleep and regular cycles. So all of these can impact how someone is feeling, how they're able to cope. And then on top of that, this change in hormones and other physiological symptoms that might come up. After the main sort of reproductive years, women can start to go through perimenopause. This also varies. This can onset late 30s, early 40s, but around mid to late 40s, this is the average age. At this point, many different body changes can happen. There's lots of symptoms that come up, such as hot flashes, feeling um, feeling different effects of heat or mood changes. There can be sexual discomfort or dysfunction, lots of mood swing type of experiences that happens. And as we saw on the chart earlier, likely this is related to the fluctuations in hormones. And as they start to taper off during menopause, this is also a time where women experience a pretty big transition in life, in that they have a different physiological set point, maybe looking towards the later half of their life. At this point, there might be more feelings of existential anxiety as the end of life becomes to be more approaching. But an interesting aside to this, though, is I was reading about how happiness in life starts to follow a like U-shaped curve, and that people are the least happy at the age of 42, and then as they go into their 50s and 60s, that happiness increases. So it's not all gloom and doom, but these physiological effects are real, and the more we understand them, and the more we might be able to offer some types of novel treatments or novel ways of dealing with these symptoms, can help overall quality of life. So if we look a little bit more closely at the prevalence of PMS, it's a very large reported prevalence, 47.8% worldwide. And 75% of women during reproductive age have experienced some symptoms. And there are more than 100 symptoms that are associated with PMS, both physical and psychological. Some of the common ones might be mood swings, depression, irritability, cramps, headaches, generalized pain, abdominal bloating, breast swelling, tenderness, and appetite changes. It's quite a many to list there. Um, One thing I don't have on the chart here that people often ask me about is about polycystic ovary syndrome, PCOS. And this is a condition where the ovaries produce an abnormal amount of androgens or male sex hormones. They're usually present in women in small amounts. And endometriosis is a condition where there's a tissues become irritated or scarring within the female reproductive system. With premenstrual dysphoric disorder, PMDD, it's 3 to 8% have extreme symptoms. That's quite a large number of people that would fall into this category of extreme symptoms. It is a DSM-5 disorder. It's classified as a depressive disorder, and there can be other psychiatric symptoms like anxiety or mood changes. The typical course of treatment is SSRIs, antidepressants, and hormonal birth control. There's also recommended dietary changes or stress management exercise to help alleviate these symptoms. But all in all, there is still a large unmet need for novel treatments with less side effects, potentially to target specific points of the cycle when symptoms come on, which we'll talk more about how psychedelics could potentially be an intervention worth studying further. So, fertility issues are prevalent in 13% of couples when women are under 30, and this jumps much higher, 22%, once women are above the age of 30. Some of the lifestyle factors can also affect fertility, including smoking, alcohol, weight fluctuations, and stress. Sexual dysfunction, 43% of women and 31% of men have reported this, and it's associated with different medical or psychological causes. Trauma is also a known factor that is more prevalent in women and can affect their ability to engage or have pleasure during sexual interactions. If we look at postpartum depression, 10 to 20% of mothers experience this, as well as fathers, although I don't know the exact percentage there for men. The idea of baby blues, it's sometimes called, the anxiety, sadness, mood swings, insomnia. And then again, the more sort of condition where someone might get diagnosed would be an inability to stop crying, very severe depression. This can interrupt the bonding phase with the newborn, or the person feeling like they just want to be alone and withdrawn from the family. Sleep issues and appetite changes. So you can imagine how much this can impact a family when a newborn or a young child is there, if mom or dad is experiencing these symptoms. So it's really important to have good support and care and ways of addressing these issues for people, for both the mother and the family. Okay, so when we look at menopause related symptoms, 85% of women experience this. I'm surprised it's not 100% just for my anecdotal um, hearing about menopause and perimenopause symptoms. Kind of already went over some of these symptoms and some of the common interventions or hormone therapy, antidepressants, gabapentin and clonidine for hot flashes, and as well as lifestyle modifications. Then when we look at life-threatening illness or end-of-life care, I'm working on a study right now that's going to be using psilocybin to address feelings of despair at the end of life. And this study is going to be enrolling both males and females that have less than a 2-year life expectancy. And the focus is on meaning and purpose therapy to help with some of these feelings of hopelessness or dread or disconnection there at the end of life, where we don't really die well here in the United States. Maybe you have more support there in Europe, or more things in place to help families and people that are during this phase of transition to have this as a access point for deeper insights and connection and emotion all the way through the final chapters of life. And so you can imagine, a lot of people feel very isolated, depressed, dread, hopelessness around thoughts or experiences as they approach the end of their life. And this can lead to decreased life quality and social connections. Okay, so now we're going to switch gears a little bit and talk about psychedelics and how they might help women across these different phases of the life cycle and across different phases of the monthly cycle. Probably you all are already pretty familiar with the topic of psychedelics, but I just wanted to point out with this slide that there are many different pharmacologies that are present with these different psychedelic substances. Even though we call them all psychedelic, they have this aspect of changing the way our consciousness is experiencing our world. It can have different subjective effects as well as different side effects. And most of these substances are considered to have a messy pharmacology, meaning that they have um, many different targets in the body. And I think if we're going to really address these issues related to women's health, we need to get pretty specific about what are the receptor targets, how are these substances able to help target physiological symptoms in particular. And then I think as a downstream effect is the psychological part that comes from the physiology. So for psychedelics, we want to think about the neurobiological intervention as well as the potential for a psychological intervention. Most of the research studies to date have focused on pairing a psychedelic substance with therapy. So there's an emphasis on both the non-drug preparation and the integrative sessions after the psychedelic experience to help someone really process what came forth from the psychedelic experience and how to work that into their life. There's a lot of mental aspects that happen at these different life transitions. So if you think about after having a baby or during menopause, a lot of these have changes in how you might view your world or how you're interacting with others, and all of this can be a lot of change. So change is always difficult for most people or maybe not, maybe it's easy for some, but I suspect many people struggle with this element of a lot of change at once. And how do we find ways to sort of find balance in our life where psychedelic therapy has a way of helping us shine a light or a lens on aspects that are out of balance with our life, whether that's work life, family balance, stress levels, any of these things. I think therapy can be a good intervention for um, reframing or helping to work through some of these difficulties. The other aspect is, our reactions are a response to pain is psychological to some degree. There are, of course, feelings or sensations of pain that come to our central nervous system, but how much it bothers us or how much we're letting it get in the way of our normal functioning has a psychological element. There's also this possibility of actually targeting through neurobiological processes with psychedelics, which have different pharmacologies, but many of them activate serotonin receptors. Other ones interact more with glutamate and GABA, such as ketamine. MDMA has a totally different pharmacology in that it can increase serotonin, dopamine, norepinephrine, and then downstream effects of that are increasing oxytocin and prolactin. So all of these potential receptor interactions are also dependent on the dose of the drug that's given. And it's pretty complicated, as we've already talked about, if we're trying to target something very specific, and we would need a lot of data and information, I think, to really uh, define how we are reducing symptoms by targeting different receptor systems in the brain or the body. The other aspect is, what about prevention or well-being? If we can help someone before something really turns into a full-blown disorder, to me, that's a approach with psychedelics that needs to be accessible in our culture as well. Most of the access that's being worked on right now is through medical use. In the United States here, we do have the state of Oregon and Colorado that have made some changes where it's not focused on medical use. And then there's a few churches that have a legal exemption in the United States for ayahuasca. And then with Native American church, there's the religious freedom to use peyote. So I think we can learn a lot from these different models and not just focus on people that have chronic symptoms or disorders, and doing more research and understanding of how psychedelics could be in a prevention or a way to bolster well-being in general. What's attractive about psychedelics compared to conventional medications, which are taken daily, often have side effects, is that with this intermittent use, psychedelics typically are administered once a month, if for these higher dose sessions, for a limited number of sessions. Microdosing is a different practice that I'll talk about in a little while, but it's that may be more frequent administrations. And this intermittent use could be particularly helpful for, say, mothers that are breastfeeding, or those that only want to use an intervention, say, a few days before they start their period, when they experience the most of their symptoms of PMS during a certain time frame. So that aspect of intermittent use is a high point for psychedelic interventions. So what do we actually know about psychedelics and some of the health issues we've discussed? I want to just highlight some of the knowledge and information that's come from indigenous plant medicine use. There's been some interesting studies that were published by Dr. Stacy Schaefer, who is an anthropologist, and so she was observing some of the peyote use amongst the Huichol Indians of Mexico. And peyote is a integrated part of their culture, their religious, their spiritual practices, from everything of like a birth ritual to marriages to death. Like, this is a fabric piece, a strong, integrated piece fabric of their experience of their culture. And so it's not surprising that they would also be using peyote in different different parts of the life cycle of females. So I'd say also a similar aspect with ayahuasca in South American cultures. I've been using these two plants. Ayahuasca is a mixture of plants that have been integrated as part of the cultures for thousands of years. It's unknown exactly how long, but there have been many years of use and how to use these plants for religious, spiritual, as well as health and physiological wellness. So what they found with the use in peyote was that they used peyote in various amounts during the different phases of birth, and also after birth, to increase the production of milk. And why would they do this? We're kind of overlaying some of the neurobiological information we have, and that we know that mescaline does increase prolactin, and prolactin is the primary hormone for milk production and milk release. It can also stimulate serotonin receptors in the uterus and cause vasoconstriction. So, if they are giving this to women that are having a difficult childbirth, it might be to help them spiritually, but also to induce these contractions after birth to help the milk come in. It's been demonstrated in rats that mescaline at higher amounts can induce contractions of the uterus. So it sort of lines up with the reported use and observed use versus what's happening in the body and in the brain. In ayahuasca traditions, including the Santo Daime, which is a church in Brazil, originated out of Brazil and South America, they have accepted the right for women to have small amounts of ayahuasca during pregnancy and during birth. It may be a symbolic amount, like a drop on the tongue, or I have also read anthropological reports about similar to the peyote use, that if someone's really struggling, they're really calling in help from ancestors, from the plant medicines, and potentially that ayahuasca is physiologically helping them through a difficult labor and delivery. It's a controversial topic in Western societies about taking psychoactive plants or psychoactive medications during pregnancy, which we'll talk about in a moment. But I also wanted to bring up this point that in 2010, the Brazilian government guaranteed the right to pregnant women to consume ayahuasca as part of their religious practice. And then they also said that it's a practice of the parental rights to say whether or not children may also consume ayahuasca as part of this religious use. And up to the parents to really decide at what age the child and which dose is appropriate. So they do have a more integrated way of working with plant medicines across the life. But with that being said, let's see. My slides aren't. There we go. With that being said, we should be very cautious when we talk about taking psychedelics during pregnancy or new mothers taking psychedelics, because they are small molecules, psychedelic substances that are lipid soluble. So that means that they can pass into breast milk. They can pass through the placenta and expose the fetus. And without rigorous research, there is no way to know like what the potential detrimental effects and what the exposure is of a psychedelic substance to either the fetus or after birth to a baby that is exposed to breast milk. Serotonin is a very important neurodevelopmental neurotransmitter, and there's very specific effects of timing with serotonin in the developing mind and brain. So any sort of disruption, we don't know what the outcomes of that could be. There's a lack of data around the risks to mothers and babies, and it is known that high dose recreational MDMA, ecstasy, or other stimulant use can have negative impacts. So we want to be cautious and not just think that there's no possibility of negative behavioral or developmental disorders that could arise. There has been one study that's looked at, I was going to talk about this one with ketamine, intramuscular ketamine use. So this was done in humans by Wolfson et al. So they measured breast milk after 2 exposures to ketamine and found that after 12 hours, there was a complete washout of the ketamine from breast milk. And so this type of information is very important for clinical practice, where Ketamine may be given to women for postpartum depression. They have it has some advantages in that it's a short acting compound, maybe a couple hour session, and then the mother could go home. Also, a time of caution of needing extra support or who's looking after the newborn and what is the appropriate time when the mother would have time to integrate and then be um, well suited to be caring for a newborn. So it's another element to think about in the interventions of psychedelic therapy for postpartum. But we don't have this information for a lot of other substances. As far as I know, we don't have this for for psilocybin or MDMA or LSD. This other point here about psilocybin, the half-life is 3 hours, so we can make some guesses that it would probably be washed out within 48 hours since it's undetectable in urine by 24 hours. But until the studies are actually conducted, we don't know for sure. It could be later. It could be a smaller amount of time that they would need to refrain from breastfeeding. So moving on, there were 78% of medication-related adverse events occur in infants under 2 months versus 4% in infants older than 6 months. So this is across many different types of medications, but what it shows is that the younger the infant is, the more likely they're going to have adverse events associated with a medication. So that time period might be important when we think about using psychedelics as treatments. And what's really clear is we just need more research. We need to know when, what substances, at what doses, type of exposure, is the infant age taken into account, and then the physical and psychological risks for both the mother and the child, and how to medicate those. There has been some research done on postpartum depression with cesarean section. So they were able to administer ketamine at a few different time points. There's mixed results across these studies. One study that administered ketamine before and then 2 and 4 weeks after delivery. They had randomized people to control or ketamine condition, and they did observe significant antidepressant effects at the 2 and 4 weeks post-birth time points. Another study, similar design, had a different dose of ketamine, a little bit lower dose, and they didn't find any differences in depression or pain measures. So this research just highlights that we need to have more individuals in these studies and look at different dose and timing effects to see if ketamine is a good option for postpartum depression. So to switch gears a little bit and talk about microdosing, um, there has been some surveys and online forums, and Dr. Fadiman reported that one of the most surprising findings that he found from the surveys that were conducted were that there was a lot of women talking about how microdosing helped with either their PMS symptoms, menopause symptoms, reduced headaches, pain, fatigue. So lots of anecdotes around symptom reduction. And then looking at online forums, people talk about periods becoming more regular, having higher doses either could shorten or lengthen menstrual cycles. So when we're talking about the full-blown psychedelic experiences, can shift cycles in some way. So that's also interesting and important to think about if people have these experiences and understanding why that is. But when we talk about microdose, it's about 5 to 10% of a normal standard dose. And the idea is that people aren't having full-on psychedelic experiences or even big shifts in sensory perception, but it's a more subtle mood effects, which if we talk about an intervention, say for PMS, that would be more advantageous than needing to go through a full experience, which I believe really needs a lot of intention, preparation, and time to integrate after. Some of the anecdotal reports that people talked about were my period was always very severe in terms of pain. The pain even went through my entire stomach, back, and legs sometimes. If I didn't take pain relief, it was vomiting because my stomach didn't pull the pain. I started microdosing, and from that moment on, I have almost no pain during and before my period. I am microdosing for perimenopause, and it saved me. Stopped my night sweats, reduced my hot flashes, and I am back to sleeping again. Seriously, a miracle. I want to share with everyone. I would love to be part of a study on the subject. I just can't find one. This may sound bad, but not completely crazy. The roller coaster of emotions that have no explanation other than hormones lessened, and the existential dread is gone as long as I dose consistently. So these are all very different, but very aligned, and highlights the need for more research into what is going on. And to me, it seems like there is a likely neurobiological mechanism, or I'd say many neurobiological mechanisms, in that the first one might be this modulation of hormones, either directly or indirectly, of circulating hormones on the major endocrine systems of the body, as well as the neurotransmitters in the brain, and how these can interact and influence each other. Remember, we talked about estrogen did both enhance or inhibit neuronal activity, or have like a dual effect depending on which system it was working on. The easing of estrogen withdrawal. So once we're hitting that ovulation point, we're seeing that drop off of estrogen. And some talk about it's sort of like withdrawing from a drug. All of a sudden, you don't have this hormone in your body, and wham, that can really hit people hard. And this fluctuation can also, as we know, start to have different effects on our psychology and how we're feeling. So, this sort of tuning may be possible with different psychedelic compounds. And again, they act on different systems that we know of. So, how do we really fine tune for the effect that we're looking for? Neuroplasticity, that might be a way that there's long term effects, like with the anecdote we just heard of someone microdosing, and then over time they saw this long-term effect of not having these symptoms. So there must be some long-standing changes that happen. And again, we don't know what happens once, if this person stopped microdosing, if their symptoms come back, or is it a way of sort of resetting the system to a different baseline that can be carried on even without the drug effect? And that would highlight something like neuroplasticity is occurring. There's also research about psychedelic substances having anti-inflammatory effects. There is a lot of information around how inflammation can cause pain. It can also influence psychiatric symptoms. More to come there. There is a CBD patch on the market for PMS symptoms where you actually just put it on your lower stomach. I don't know how much research backs up this, but I think like to think that if people can really track their information and measure data across time, then an individualized approach is where we're heading, particularly with women's health issues, because understanding, say, the timing and severity of symptoms, as this relates to the menstrual cycle, if we could even measure the circulating hormone levels, also the environmental factors such as stress, diet, sleep. Could we say, have an alert on your phone that comes up that's like, okay, it's time to take that microdose. Your PMS symptoms are set to happen tomorrow. So if you take a microdose today and the next day, that might help alleviate symptoms. We don't have this information yet, but with technology, I feel like the integration of data will help individuals have this type of approach, which I think is going to be the best way to mitigate symptoms, but then also reduce the likelihood of tolerance. If someone takes a psychedelic repeatedly, that's a potential tolerance to the beneficial effects. So we know with other medication side effects from daily use. So this idea of like directing interventions to different points of the cycle, maybe the same would apply to fertility issues if it is possible that psychedelics could tune hormones or something of that nature. And then the other aspect of like the cluster of symptoms around perimenopause and menopause is this idea of a personalized approach to adjust around the symptoms, and then monitoring what you're actually feeling and adjusting based on that with hopefully recommendations based on research and evidence-based approaches. All right, we're getting towards the end here. I hope y'all are hanging in okay. I think we're a little over time, but I'm going to keep going. So where are we with like addressing women's health issues with psychedelics or psychedelic therapy? There are lots of indications that are under research right now that impact, as we know, females are experiencing a lot of these symptoms. So all the research findings that come out of this may be applicable, but those that are specifically focused on women's health issues, postpartum, there's a study with 5-MeO-DMT that's being conducted. The Mycomedica Life Sciences, which is Paul Stamets' company, has put out that they are going to be looking at the psilocybin microdose formulation for PMDD, and really excited about that because as we just were talking about, it would be applicable for so many people, and potentially the research findings would help really dial in how to apply psilocybin for this. And then I know of another study that's going to be enrolling new mothers that have postpartum depression and comorbid opioid use dependence. This is an extremely vulnerable population for both the mothers and the baby. So if we can have an intervention like MDMA-assisted therapy that could have potentially a lot of impact to disrupt the harmful substance use and at the same time address depression, it does seem like a great study and research to move forward with because of the potential impact on the family. There are lots of different substances, therapy approaches. I'm really curious though, like, are there optimal times during the cycle when people should undergo psychedelic therapy or during the life cycle that would be most effective for a given substance or a given approach? So lots of questions there to address. And then again, we already know that there's sex differences between different drugs and medications. Some of this research that's on this slide really highlights the idea that for, say, cocaine seeking or in women that are dependent on cocaine, that will sort of fluctuate across their cycle, how much they're craving it, how much they're using it. So again, this speaks to the idea of some influence of the hormones. We know that in PMDD, there's an increase in SERT binding across the menstrual cycle, and that this can be respond quickly to SSRIs in some people, not everybody. So because of this response to SSRIs, it does suggest that serotonin could be a key target for mitigating some of the mood effects that are associated with hormone fluctuations, and that women are more likely affected by negative subjective experiences of MDMA and also experience greater cardiovascular effects, such as an increase in heart rate and blood pressure. Again, highlighting the need for looking at responses in study data, like doing analysis across different genders to see if there's any potential risk or side effects to be aware of. Interestingly, though, I think in the MAPS recent studies, the phase 3 studies, they didn't detect these cardiovascular differences between genders. This could be related to sample size, to dosing, or that the effects are just pretty small. In analysis, sort of show the averages are more similar than different. Okay, so for the future directions, we really have to look at these different factors and how they come together and overlap, as well as can we sort of tease them apart in our study design. So we want to look at neurobiological, psychological mechanisms, how the environment impacts that, as well as substances and doses. And I think this environmental piece is uh, less talked about during psychedelic therapy and the outcomes. But if someone is, say, being treated for post traumatic stress disorder, yet they have to go home to a very stressful situation where they're experiencing repeated traumas, like we can't expect that the MDMA therapy is going to necessarily like override their symptoms or override what's happening from the triggers in their environment. And I think this would be the same for something like postpartum depression, of if we're not also getting mom support, psychological, social support, having other ways to mitigate stress, then the reliance on ketamine and might just become like a quick relief for a little while, and then symptoms come back. So we want to understand how to treat holistically the whole person and taking into account what's going on at home or in their environment. So yes, to get across the life cycle, I think there's lots of opportunities for research and potentially interventions for women to live a high quality and healthy life. So thanks so much. I appreciate your attention, and do check out our resources at Psychedelic Support. We have continuing education as well as free monthly webinars where we invite different speakers to come give presentations like you heard today. And so if there's time, I'll take questions, and appreciate being here.
Yeah, thank you so much. It was a really great presentation. Super cool. Yeah, maybe so if one of you has a question or more, feel free to ask. Or just unmute yourself.
I have a question. Yeah,
sure.
Great talk. Great talk, Allison. Thank you very much. I have one question. Since ketamine is being used widely, is there any evidence, or is there tracking of the effect of ketamine or effectiveness of ketamine and cycle and the yeah?
I haven't seen anything yet, but if somebody finds something, let me know, because I am always updating this talk. But as far as I know, it's as we spoke about, not well researched to really try to tease out the effects of certain drugs and how that relates to cycle, whether or not effectiveness. And maybe it's because most medications are prescribed every day. And so that idea of like how is the cycle impacting the medication effect is less prominent, but I think it would be very important and interesting to look at.
And the continue. If I may ask, like a question which continues on this. So now that all the clinical trials are being designed, is this even asked or taken into account, like which day of the cycle a woman participant is in?
I haven't seen that collected in the studies I've worked in or seen it reported. So yeah,
I mean, because there's a
I'm,
huge amount of data being collected. So
yeah,
if this information would be there, we could even kind of try to look at it.
yeah. So one thing with the MDMA trials I worked on, and I think this is consistent across most psychedelic trials at this point, is that women have to agree to be on 2 methods of birth control. Many are on hormonal contraceptives. So also an important data point to collect, but I don't think that is actually really recorded or analyzed. It might be recorded as a way of demonstrating that the person is preventing pregnancy during the clinical trial. They also do a birth control test the morning of the MDMA session just to ensure that there won't be a exposure to a fetus. And this is all like FDA regulations, which is changing over time and as there's more information and data around safety. But nonetheless, in clinical practice, it's probably a recommended procedure because it's low cost. But yeah, that would be really cool to analyze, just like what day of the cycle were, what type of birth control, was there any effect on blood pressure or other cardiovascular vital signs that are recorded during the drug session, and then after, if you look at the potential response to the treatment.
Exactly. Yeah. Okay. Thanks a lot.
Yeah. Thank you. So so I also have a question. So you said that estrogen can induce, for example, white matter brain structure changes. So my question would be whether these are also fading again and coming back across the cycle, and maybe if this is the case, would it be good then to also adjust psychedelics treatment, for example, for depression, to have these sessions when the brain is in a more neuroplastic state, if the estrogen levels are high, or would you rather think, okay, better take psychedelics to compensate for the lower levels of estrogen?
Yes, I think so. Like, they've kind of, I didn't present this and I'm a little sketchy in my memory, but there is some, so we talked about differences in cognition, or that you might be a better problem solver when estrogen is at a higher level in the body. And therefore, maybe, you go through psychedelic therapy during the phase where estrogen is high, that you're more receptive to the therapeutic approach. You're able to bond more or have a better therapeutic alliance with the therapist. You take a bias towards positive insights rather than focusing on negative, or that you're able to reframe your negative or traumatic experiences because you're bolstered by estrogen. It's possible, I do think that it's worthwhile research because it's going to be an expensive treatment if you do the full course of therapy and psychedelic experience. Then optimizing that timing would make a lot of sense.
So would you then say it would be a good suggestion for clinical trials that every woman just downloads those apps that you showed, so and sends this data to these?
Yeah.
That's right.
Yeah, or real world data, right? Like some of these survey responses could have, and perhaps that's, I mentioned Mycomedica, which is Paul Stamets' company. So they did a large survey on microdosing, naturalistic use, self-report. So perhaps they collected some information about that and decided that was a good indication to target PMDD. I don't know though, but.
Yeah, thank you so much. Okay, so from the other ones, do you maybe have a question? Although for us it's in the evening now, and yeah, just unmute yourself and say something. In the meantime, maybe I already announced our next upcoming two meetings. So our next meeting is on the 17th of April, and Mark Wittmann will give a presentation about the about the interplay between time and self and creating flow states. And on the 23rd of May, Marco Filippi, a PhD student of Marco Fissler's lab, will present preliminary results on the effects of psychedelics on mitochondria and their role in psychiatric disorders. So maybe, Allison, do you know whether mitochondria, also the activity might change, or have you read something about mitochondria and sex hormones?
Yeah, I don't know. You should save the question for your next speaker.
Yeah.
But I did, in putting together these presentations was just the interaction with so many different neurotransmitters and systems in the body. I gained a much greater appreciation for that. With those seem like we didn't learn that much about in our programs with neuroscience. It wasn't necessarily the focus, but should be. I mean, just like diet and exercise and other environmental factors can influence our physiology so much. So
maybe just one last question from my side. So I'm about to finish my studies, and now how do I phrase it? So you address super good points, but still have the feeling that these are always things, yeah, this should be done in clinical trials, and yeah, it would be good to address this, and you are one of the main persons who are advocating these ideas or these suggestions. But what would be your recommendation for people like me? Are there some open petitions or something where I could subscribe or just say, yes, you have my voice? And so many young researchers would also like to press these new measurements in clinical trials, or do you think all of us need to wait until we are professors and creating our own or leading our own clinical trials?
yeah, I think just having the conversations about it and looking at research that we have, and then as you're able to design studies, baking it into the design of how do we start to address these questions? How do we focus more studies, particularly on women and women's health issues? Part of that is about getting funding, so helping to advocate to funders or lab directors, university heads of why this is important, right? So yeah, I think that can happen in many different ways, whether you're posting stuff on social media, hosting talks, planning studies, highlighting, underscoring the need for more research. And so I was really thrilled to see these studies recently in Scientific America about how the brain changes across the menstrual cycle, and helping to bring more clarity around, like, no, this is not just like crazy women, just like, and there's actually, these are real symptoms, these are real experiences. This is not, I think back in the day, they used to sort of call it manic stages or weird things like that, just sort of brush it off. Like, but the more we understand it and research these topics, then the more likely we'll have good interventions and just good ways of coping and understanding.
Yeah, thank you so much. Yeah, Prateep.
On that, I actually worked on cortical inhibition. So we even have a physiology paper. It was in rats, but female rats, following the activity of interneurons and how this changes over the cycle. And we observed that, we reported that, it was published in Current Biology. And then they, of course, asked, what is this good for? And we found it really difficult to, now that I think of it, now there are these neurons deep in the cortex which kind of connect to these layer 4 interneurons, and these layer 6 neurons are activated by psychedelics, So if one would like now think back in hindsight, so probably there is this tight correlation between the neurons which are activated by psychedelics, like the 2A classical psychedelics, and these which are very particular set of interneurons full of estrogen 2 receptors, so the 2A, and they're like super active during the menstrual phase. They just fire like crazy when estrogen goes up.
Sounds like a good follow-up study.
Yeah.
Psychedelic
So
effect.
there's a lot of neurophysiological changes, like brain-wide.
Yeah.
Yeah, Silvia.
Hey, I also have a question, because I read some studies before and also in your talk, mostly it's focused on the estrogen levels, like the neuroprotection of the estrogen. And I was wondering if what would you say about like the progesterone levels? Could they also be like neuroprotective or?
Yeah,
I mean,
it's
because they also go down with the estrogen, and mostly it's focused only on the estrogen and not on progesterone.
yes, I've gotten this question before in giving this talk, and I need to go back and really dig deeper, but it is true that a lot of the research is focused on estrogen, and but they both do work on HPA axis, HPG axis, it's modulation in the brain. So there is some effects, whether it's opposing or modulation. But yeah, most of what I've been reading is talking about the estrogen levels and then this withdrawal from estrogen, this experience of um, like almost being in withdrawal from a drug, but from a neurohormone. So, but yeah, I welcome you all to. I'm easy to find online. So if you find interesting studies or other things that I could add to this talk, let me know, and I'd be happy to include it.
Yeah, thank you. Okay, Jelle now.
Hi, I just wanted to, thanks for the very nice presentation. And yeah, I have a question. First, I noticed that in a lot of psychedelic studies, usually there is, higher percentage of men enrolled in these studies, even though, these are studies for depression or, many of these psychiatric diseases, which are more prevalent in women. And I was always wondering, what do you think? Why is it like that? Is there some bias with enrollment? And is it also maybe a way how we are lacking certain data regarding, women? And if you know how these treatment responses compare between males and females?
Yeah, so I know with the FDA studies here in the United States, you do have to do analysis to look at different responses between genders. The MDMA studies with MAPS actually enrolled more females than males, but I don't know why if studies are enrolling more males, but I do see that the psychedelic therapy studies, it's a lot of time that you have to devote to going to the study sites. And, women often are raising kids, there are more pressures at home. So maybe the time commitment too, to like take off work or take off time from family life potentially could be a reason. Or, maybe even symptoms being more chronic that, less motivated to get out and join a study. I don't know though how the recruitment is different or why there might be more men. But I think psychedelic in use too, if you just look at the naturalistic sample, can be more prevalent in men by not a huge percent, but somewhat. So that perhaps is part of it as well.
Okay.
And regarding treatment responses, do you see some difference between men and women, or did anybody compare that?
Yeah, not in the not as far as I know, not in the studies that are looking at psychiatric symptoms, but you can find studies that were with MDMA that have found differences between men and women as far as cardiovascular effects, potential side effects. I kind of covered some of that in the talk. So there can be drug differences with psychedelics, and maybe it's related to dosing as well. But mixed results there.
Yeah, thank you, and thank you for letting us overrun. Then I think we are at the end of our meeting, and yeah, again, thank you so much for your time, and for all the information.
Sure thing. Thanks for having me and your attention today. Have a good evening.
Yeah, and
Thank you very
a nice
much.
day.
Bye-bye.
Okay.
Bye.
Yeah, keep up the great work. All right, ciao.